off. Well, good afternoon, everyone, and welcome to the Masonic Cancer Center's June Fireside Chat. This Fireside Chat is in honor of National Cancer Survivorship Month, and today's conversation highlights a critical but often overlooked part of survivorship: caregiving. There are more than 18 million cancer survivors in the United States today, and behind many of them is a caregiver who has walked alongside them through diagnosis, treatment, and beyond. Yet far too often, caregivers navigate this journey without recognition, resources, or rest. So today we will be exploring this topic, as well as time toxicity, a term used to describe the hidden cost of cancer care, which impacts both patients and caregivers. Our expert speaker, Dr. Arjun Gupta, will dive into that concept a little bit later on in our session today. I'm Amna Hussein. I'm the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, and I will be today's moderator. These Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota, which serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our dedicated team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Today, we are incredibly fortunate to be joined by two remarkable individuals who are helping change the way we think about caregivers, one through lived experience and advocacy, and the other through research and healthcare systems change. It is now my pleasure to introduce our first speaker, Allison Breininger. Allison has a master's in education and spent 20 years teaching, training, directing, coaching, and creating content in the realm of education. At 31, she became a caregiver for her husband, Sean, when he was diagnosed with a rare genetic disease called Fanconi anemia. In the 13 years since, she has been by his side through a bone marrow transplant and cancer of the tongue, throat, gums, bladder, esophagus, and skin. In those years, she has experienced firsthand that caregivers are in the negative space, vital yet overlooked and under-supported. Fueled by what she saw and what she experienced, Allison founded the nonprofit The Negative Space as a way to use her experience and skills to change the way caregivers are seen and supported. Through The Negative Space, Allison shines light on the realities of caregiving, provides direct services to caregivers, and educates and equips those who support them with concrete tools and strategies. She co-hosts the In Sickness podcast, provides individual coaching to caregivers nationwide, facilitates support groups and education sessions, partners with multiple organizations to more intentionally support caregivers, and sells caregiver gift boxes. After Allison presents, we'll hear from Dr. Arjun Gupta, a medical oncologist and assistant professor of medicine at the University of Minnesota Medical School. Dr. Gupta is a symptom management enthusiast, health services researcher whose work focuses on cancer care access and delivery, the cost of care, and the hidden burdens placed on patients and caregivers, particularly during active treatment. What makes today's conversation especially meaningful is that these two speakers have been working together to elevate the voices of caregivers and shine a light on the hidden burdens they carry, making them the perfect pair to lead us through today's discussion. They've even hosted a podcast episode on this very topic, which you can find on The Negative Space if you're interested in continuing and hearing more about this conversation from them. So before we dive in and before I pass things over to Allison, we have just a few housekeeping items that we'd like to cover. So today's Fireside Chat is recorded, and the recording will be made available on the Masonic Cancer Center's YouTube page. For any University of Minnesota employee or spouses participating in the university's employee wellbeing program, you can earn 200 points by completing the form that will be linked in the chat shortly. And during the presentations today, please use the Q&A feature, which is located on the bottom of your Zoom screen, to submit any questions or comments that you have. We have some time carved out at the end to take some audience questions. And without further ado, now I'm going to pass things over to Allison. The virtual floor is all yours.
Thank you, Anna. So glad to be here and excited to be able to share my story with the group that has gathered here today. One second. There we go. So you did a beautiful job introducing me, but just a little bit more that yes, I am a caregiver to my husband, Sean, since 2011. And with that, then have become a caregiver advocate, a founder of a nonprofit, and a co-host of a caregiving podcast called In Sickness. So just a little bit of our story to kind of share with you how it is that we got to be where we are today and where my interest in this topic came. I married my high school sweetheart in 2002. We adopted our daughter from Haiti in 2009. And just a year after she came to Minnesota, my husband, Sean, started displaying some strange symptoms. We spent about a year trying to find a diagnosis. And in July of 2011, he was diagnosed with a rare genetic disease called Fanconi anemia. We did not realize this at the time, but we are very fortunate that the University of Minnesota is one of the world's leading headquarters for this disease, and we just happen to live 15 minutes away from it. And so he has received all of his treatment there, and we know many people who have flown from across the world to come to the U of M for treatment for this disease. After his diagnosis, he had a bone marrow transplant at the University of Minnesota in December of 2011. Since 2011, he has experienced 150 skin cancers, 8 oral cancers, tongue cancer twice, one of which required the removal of half of his tongue and all of his lymph nodes on that side, bladder cancer, a very rare kind, which meant that he needed to have his bladder, prostate, and lymph nodes removed. Throat cancer twice, one for which he had surgery and one which required 35 days of chemo and radiation. And esophageal cancer. He, at this very moment, has 5 active cancers inside him that we are preparing for surgeries to remove. So we've been going through this since 2011, and it just continues. So when you hear all of that, the things that you might imagine are pictures like this. But what you may not picture is this. So I have been present for, I would say, 96% of Sean's appointments and procedures and hospitalizations and ER visits. And each one of those things in the medical spaces and in our home has had a distinct impact on every piece of my well-being. And yet, very rarely is that acknowledged by the world, by our society as a whole. So I like to say that caregivers are in what we call the negative space. That's from the artistic term of everything that's in the background of a picture. We are a vital part of that picture, and if we went away, everything would change. And yet we very often go overlooked and unappreciated and unsupported. We are in the negative space. So even if the pictures that I just showed you have sort of, changed your focus to be able to adjust to see caregivers in these medical spaces, there's so many additional aspects of caregiving that are unseen and that often happen before, even during, and definitely after these medical appointments. Things that, as Dr. Gupta will explain shortly, take time from us, but that also have far-reaching implications on the caregiver's well-being. So to name just a few, because the list is long, caregiving has an impact on our homes, on parenting, on working, on the financial and legal aspects, on our physical health, and on our mental health. And so to describe just a few of those, Our home since 2011 has been taken over by medical experiences. We have had nurses come in through our house. This picture on the left is actually, we were on a vacation, but because he had a line at that point, we had to have a nurse come into our vacation space. On the right, you can see that we have medical supplies all over our house. And one holiday, I tried to even make them a little more festive to try to fit in with the house a little bit better. But it kind of messes with your head that even in your home, the place where you're supposed to be the most comfortable, this medical experience that you as a caregiver are going through just kind of permeates every piece of it. Caregiving has impacted my role as a parent. Our daughter was around 4 or 5 when my husband went through a bone marrow transplant, and we had to figure out how could we include her in a way so that she'd feel involved but not scared. And so in this picture, you can see her helping put on his little hospital, his sketchy socks there at the beginning. Something that was she could be involved with, but nothing too scary at that time. Over the years, I have felt constantly pulled between these two very important people in my life. You can see here a picture of me in the hospital with him FaceTiming her at home. And then you can see me at home with her FaceTiming him in the hospital. And in both situations, I felt like I was in the wrong place. There were times that she would be little and would be sick and I would want to snuggle with her, but I would know that I couldn't afford to get the bug that she had because I might pass it on to him. And so the parenting was impacted because I constantly felt like I was in the wrong spot. I was being pulled between the two of them. It impacted her so much that when it came time for her to start looking at colleges, she looked at the University of Minnesota in Duluth. And after that tour, came home and said, it reminded me too much of the hospital because all of his treatment was at the U of M Minneapolis. The colors, the signs, the logos had such an impact that it even determined where she ended up going to school, where she ended up not going to school because of those experiences. Caregiving has impacted working. I have sat here on a Zoom call and hooked him up to IV fluids while leading a call that no one knew what was going on in the background. I have interviewed people from walking between the clinic and the hospital. I have trained rooms of people after sleeping in a hospital chair overnight. In this picture, that's at the U of M clinic, and I had a speaking gig that day, but he had an infusion, and I just sat there in that chair hoping everything went smoothly and that I would be able to race home and get onto the call in time. And so about 2/3 of us caregivers work in addition to caregiving. There's so many reasons why we need to. And so I just want you to think about the gymnastics that have to happen every time a caregiver has to attend an appointment or be at the hospital bedside when they're trying to work at the same time. Caregiving also impacts us in a financial and legal way. Caregivers spend a lot of time looking just like this on the phone trying to deal with systems that are largely broken and trying to understand what's going on and what are our rights and all of those things. So on the phone with insurance and bills and Medicare. And so this is a picture. I wish this was a stock photo, but this is a real photo from bills from our house, from medical bills. And there was a season in our life where it was so stressful for the stack of mail to come through our mail slot every day that I had to tell my husband, Sean, like he couldn't even look at the mail anymore because it was impacting him so much because there were so many bills and notices and the letters, and many of which were inaccurate and that we had to fight. So I took that task from him, and then that meant that it was solely on me, right? So another piece of caregiving that landed on me. There was a moment in which we found out his Medicare benefits had changed and we're no longer going to cover some of the materials that would get delivered to our house. And so I had a moment of having to sit on the front steps because I was told that if we brought those materials, medical supplies into our house, we would have to pay for them. If we didn't bring them in and they got picked up again, we wouldn't have to pay, but then he wouldn't have what he needed. So here I am with no medical training, sitting on the front steps, trying to make these decisions about spending thousands of dollars on these materials that he needs, but spending money that we didn't have. And so again, here's another piece of caregiving that is so often overlooked. You think about the impact of a moment like I just described, or the moments like you see here on a person's mental health. So I have seen and smelled and heard and experienced things being done to my husband that will stick with me. And we have to, because of all these years of all these appointments, we have to continuously go back to the scene of the crime, the place over and over and over, a place of healing, but a place that can feel in the moment like they are torturing him, even though it's all for the good. And that can really mess with a person's mental health. That on top of the fact that I love the shirt that he has, but that he is currently 8 years past the median age of death for his disease. So living with that knowledge weighs on my mental health as well. And the research definitely agrees. They say that caregivers of people with head and neck cancer have the same rates of PTSD as the patient. That caregivers are 90% more likely than their peers to experience anxiety daily. And that 70% of caregivers show signs of clinical depression. So it's not just my personal experience, but the research agrees. There's also an impact on our physical health. Think about all the nights that I have spent in a space like that, about the lack of nutrition, the lack of exercise. Caregivers are notorious for, we don't go to our own appointments and our own screening because we spend so much time already at the doctor's office that often we don't go to our own and take care of our own health. Caregivers are much more likely to suffer from stroke and heart disease than our peers. And many of those impacts last long after the person has passed. In fact, a really staggering statistic is that caregivers have a 63% higher mortality rate than our peers, and that many of the caregivers who are caring for someone within the Alzheimer's community pass away before the patient from stress-related illnesses. And so imagine, and when Dr. Gupta talks about time toxicity today, some of the ways that we're trying to solve for time, the time burden, is by reducing the amount of time people go into the clinic, by sending them home earlier from the hospital, by doing more in the home, which benefits in some ways. And we have to think about who bears the burden when more of this care is happening in the home. It's often the caregiver. And so that's an important piece to remember as well. So imagine having all of these impacts on your life and your well-being that I just mapped out. And that was a very short version. And then being really largely unseen by the world while you're going through this. So there are 53 million caregivers in the US. I really think that's a low estimate, but that's the number that is out there at this point. And yet we're in the negative space. We're this vital part of the picture. Without us, everything would fall apart. And yet we're largely unseen, unappreciated, and unsupported. So Daniel Goleman says that a prerequisite to empathy is simply paying attention to the person in pain. And so the mission of the negative space is to change the way that caregivers of all kinds, not just cancer, all kinds, are seen and are supported, and to help us as a collective, to start paying attention to someone who's often in the shadows, often in the negative space, but who's often also in pain, the caregivers. So hearing all this, I hope, makes you want to go check on the caregivers in your life. And what you might fall into the trap of is going to them and saying, like putting on your puppy dog eyes and saying, are you taking care of yourself? And that's a trap we don't want to fall into. It reminds me of my favorite quote, which is shouting self-care at people who actually need community care is how we fail people. So we want to figure out, how can we all show up for caregivers and provide them with the care that they also need and deserve, instead of just adding more to their already overflowing plates. So here's just a few quick ideas. Start seeing caregivers. I sometimes have people say, well, I don't know anyone who is a caregiver, to which I say, baloney. We all know so many caregivers. And so start paying attention when someone says, oh, I was just at my aunt's house filling up her pillbox. That's caregiving. When someone says, oh, I just had to drive my dad to his physical therapy appointment, that's caregiving. So start seeing caregivers. When you see caregivers, acknowledge them, thank them. That goes a long, long way. When look for practical ways to make their days easier and to provide support. I'm not going to delegate sitting bedside. I'm going to still be the one to sit bedside with my husband. I am going to delegate things like raking my leaves, walking the dog, bringing us dinner, right? What's a practical thing you can do to provide support to a caregiver? If you're a medical professional, can you make a little chart about the caregiver? Can you remember something about them as well? So that the next time they come, you say, hey, didn't you say last time you were going to start a garden? How's that going? To make them feel seen and like they matter too. A few helpful phrases that you can say. Some of these are geared more towards those in the audience who are medical professionals. Some are more just for any of us in the community. But saying, I imagine it took a lot to get here today, and that you may have had to rearrange your schedule to do so. Thank you. You know what would happen if you said that to a caregiver? They'd cry because they would feel so seen in that moment because they likely had to do a lot of gymnastics to be in that appointment. I know that caring for a loved one can be a lot. We care about your well-being too. And so here's some resources for you for wellness visits, mental health support, and for screenings. Caregiving is hard. Don't forget to take care of yourself. Wait, no, that was a trap. We're not going to tell caregivers to take care of themselves. Their plates are already full. Instead, we're going to say, we're going to tell them how we're going to show up for them. We're also not going to say, let me know if I can help. Don't leave that open-ended thing out there. Instead, be really specific. I would love to bring your family dinner this week. Would you prefer Tuesday or Thursday night? Or sending a text message, thinking of you as you wait for these test results. No need to respond. Just know that you are loved. I love that no need to respond because otherwise it's something that went just back on my to-do list that I need to respond to someone. And otherwise, if they say no need to respond, it was just a gift that I was given, that someone's out there seeing me in this isolating and lonely journey that I'm going through. So those are a few helpful phrases. For those of you in the audience who are medical professionals, we have created at the Negative Space an inventory that systems can use to say, how are we doing in our system on caregiver support? It's a rubric that you can use on your own. It's a self-assessment that just gives you a picture of what it is that you're looking for. And so if you're interested in learning more about that, you can reach out to me. I'm also really proud to share that Dr. Gupta and Dr. Warrior and I together wrote a page that was published in JAMA. It's a page for caregivers, and you can scan the QR code there. You can get it. You can give it to patients. You can read it for yourself. It's just a one-pager, but just even the fact that this medical journal dedicated a whole page to caregivers is a big deal. And so we're excited that that's out there. The Negative Space itself, we offer bi-monthly virtual caregiver support groups. I offer one-on-one virtual support. We have the In Sickness podcast where Dr. Gupta was one of our favorite guests. We are on social media. We have caregiver gift boxes, and then I'm available to do speaking and training such as this. And then we also just launched a great new online resource for caregivers, knowing that they can't always come to a support group. They can't do something that's scheduled. Often they need help in the middle of the night or in that surgery waiting room. And so this is called the Storyline. It's online, available to caregivers if their person is newly diagnosed, or if it's surgery day, or if they're trying to navigate loneliness or working while caregiving. They can click on that button and then they can find a whole slew of tools and resources meant to meet their need in that moment that they're in. These were all created specifically for the Storyline, specifically for caregivers. So everything from reflection questions to guided meditations to yoga to all of the different pieces are there. And so that's a new tool that is available for caregivers. So with that, I will pass it back over to Amna, and I'm excited to having the conversation with Dr. Gupta in a moment.
Thank you so much, Allison, for that deeply powerful and personal reflection, and for all of your work in building spaces, tools, and resources that center caregivers. Now we're going to shift our focus to the clinical and research perspective. So Dr. Gupta will take us into a broader look at caregiving experience and cancer survivorship through the clinical and research lens. He'll highlight the hidden burdens patients and caregivers face in survivorship. He'll define the concept of time toxicity and how healthcare systems can better support those providing care. So Dr. Gupta, I'm going to turn things over to you.
Thank you so much, and very tough act to follow, Allison. It's a joy to be here. I think I need to unsend some of my recent text messages, which for sure said, let me know if I can help. So good learning for me as well. I'm a gastrointestinal medical oncologist at the University of Minnesota. And one of my passions is not doing stupid things that make life tougher for people affected by cancer. I don't have any disclosures today other than the fact that I'm wearing pajamas below this shirt. This concept, which guides my professional mission, is people with cancer and people affected by cancer, their care partners, often have limited time. And it is our sacred duty to not take up more of that time than is absolutely necessary. And this was drilled very early into me during my oncology training. In 2018, I was a first-year oncology fellow, where I read this quote by Henry Thoreau in the Journal of Clinical Oncology, which is one of our most important journals, and it had a striking impact on me. We know that there are terrific advances in cancer care and more drugs and treatments being approved. And yes, these have helped people live for years and decades longer, and I'm very, very pro or for these new fancy treatments. These treatments often also come with a lot of hype. So you look at the Time magazine covers from left to right, it's from 1980 when interferon was proposed to cure all cancer. And then around the turn of the millennium, when it was imatinib or Gleevec for a type of leukemia. And then 15 years later, in 2015, it was immunotherapy. And yes, these all represent amazing advances. But the sad reality is, most people with cancer will still die of their cancer. In fact, most new cancer treatments offer very, very marginal survival benefits. In this analysis, of the last 100 drug approvals or so in the United States, the average survival benefit was less than 3 months. And yet, these treatments can take a lot of time away from patients and care partners in waiting rooms, in transportation, on annoying holds with the insurance company. I think we can all relate to that. And I think we have a problem in the oncology community. I think we don't do a good enough job acknowledging or addressing these time costs of care. When we start reporting survival benefits to decimal points of months. So many oncology clinical trials now say this drug made you live 1.1 month more or 1.01 month more. And just to think about what 0.1 month and 0.01 month means, it's 3 days and 7 hours. And so when we're talking about such little benefit, it becomes even more imperative to think about how much time is being taken away from me if I'm pursuing these fancy treatments. And so it's in this context or space of sometimes new treatments providing very marginal survival benefits that we thought about time toxicity or the time burdens of cancer care. Because if these marginal survival benefits are overtaken by the time costs, should we not be more honest with patients and care partners? And that's really the genesis of time toxicity, a term that we coined 2 or 3 years ago. And it's all the time costs that go into receiving cancer care. If we agree that this concept is important, a very important next point is, how do we measure it? Now, it's very easy to measure time in general. You can just talk in seconds and hours. But it can be very difficult to communicate time to people in a simple way. For example, if I was to tell you that treatment A will involve 13 hours of infusion and 24 minutes of driving and 16 hours on the phone, and treatment B will have similar numbers, your mind will go tizzy. And that's why we need a very, very objective, very practical, very intuitive measure that still captures patients and care partners' values when we're talking about time. And after doing lots of mixed methods work, which means both qualitative and quantitative work, the measure that our team came up with was called healthcare contact days, or a day with healthcare contact outside the home. So this meant that people told us that any day that I have to get out of bed, get out of my pajamas, get into a care, go to the clinic for any reason, for any length of time, even seemingly for a simple blood draw, which is supposed to take 10 minutes, takes the whole day away from me. Those appointments for 10 minutes never actually take 10 minutes. They end up taking 3 hours. And then I'm driving to, parking, waiting. I have to arrange childcare or elder care, and my loved one has to take time off work. And so it takes up that entire day. And so we describe all of these sources of visits, either to the actual hospital, to a rehab facility, to the emergency room, to the actual clinic, as a healthcare contact day, no matter whether the objective time spent on that day is 1 minute or 7 hours. And so some of this was born from these very powerful quotes from care partners and patients about how even seemingly short outpatient appointments turn into all-day affairs. When we presented this concept to the oncology community, there was pushback. They said, you don't know what you're talking about, and a blood draw just takes 5 minutes. This doesn't make any sense. So we actually reviewed the data at the Clinics and Surgery Center at 909 Fulton. Patients and their care partners get badges that allow us to track their location within the cancer center. So we actually looked at how much time are people spending inside the clinic for seemingly simple appointments. These are the sort of badges. And we found that even for blood draws, people were spending more than 2.5 hours within the cancer center. When you add in the driving time and the parking time and the walking from the garage to the entry of the clinic, this exceeded 4 hours, even for the simplest appointment. And so if we agree that time toxicity is important, and healthcare contact days is a decent enough measure of time toxicity, how might these data apply to clinical trials? So we looked at a clinical trial that was done a while ago. It was completed. In that clinical trial, around 600 people with colorectal cancer were randomized to receive either weekly chemo or no chemo. And the people receiving chemo lived approximately a month and a half longer than people who did not get chemo. So that's around 6 weeks of extra life coming in every week. We went back to this clinical trial and reanalyzed the data. Each day of clinical trial follow-up was marked either as a healthcare contact day or a home day, where someone is purely home. And this is what the data look like. We can see that contact days were higher in the chemotherapy arm. We can see that home days were also higher in the chemo arm, but this was not statistically significantly different. But the real kicker was the 18% of days spent with healthcare contact versus 6%. And I argue that how you present this data to a patient and care partner will elicit very different choices from them. Whether you say this, or whether you say this. And I believe it's for the patient, the caregiver, and their oncologist to together decide what treatment makes the most sense. But the sad reality is, at this time, clinical trials do not report time toxicity. This has not been a conversation that's been active in the oncology community. And so in our current work, we're focused on changing how clinical trials report data, but also supporting patients and care partners currently in our healthcare system with appropriate supports to counter this. And we've made some progress. Our biggest professional organization is the American Society of Clinical Oncology. And you'll notice this was some guidance sent to abstract discussants at last year's meeting. And for the very first time, they asked abstract discussants to specifically discuss the time costs associated with the treatment. So I do think that the field is changing. something we noticed as we focused on healthcare contact days and care outside the home and time outside the home is that we were ignoring the time burdens at home, as Allison brought up. And so people definitely brought up all of these themes when talking about time costs, but they also brought up how care partners were affected. And also all of these tasks that often fell to care partners. So insurance and bills and my chart and calling people and insurance and fighting with them. And all of these tasks can lead to all of these psychosocial issues and burdens. It's demoralizing, it's dehumanizing. You don't succeed. You throw the phone in disgust. You just forget about things and bang your head against a wall. And so these are just some sample quotes from recent patients. And I think anyone who's received any healthcare, this will resonate. Another one from a care partner is this, about how medical bills make no sense and how much time is spent in addressing all of this. And so as we've advanced the concept of time toxicity, we've also started to recognize these invisible time burdens that are actually not captured by contact days, how they're often not value added, and even seemingly well-intentioned clinical teams like myself or our team are unable to directly help patients with this, and how they often lead to abandonment because there is just no way to succeed. The system will always win. And we've titled or named this as the logistic and administrative burdens of cancer care. We recently completed a clinical trial where we proactively connected people with colon cancer with a nonprofit in Minnesota called Cancer Legal Care, which is a pro bono group of attorneys that help with all sorts of issues faced by the patient and the care partner to sort of proactively preempt and manage all of these health-related social needs, such as medical debt, insurance issues, medical bills, all of this stuff. And I'd like to end on a somewhat positive note. I think there's a lot wrong with the healthcare system, but very little has to do with the people in healthcare. Most people that went into medicine went into it for the right reasons, and we're working very, very hard against the tide. And so we see this where as we asked clinicians about patients as time toxicity, clinicians actually said this: I want to help, I'm not able to. And I found this quote online that the biggest, with AI, with all of this, the biggest tech advance will actually be more time with patients. I don't know who said it, but I know they were pretty smart. And I'm hopeful that with all of this, we'll be able to get back to person-centered care rather than cancer-centered care. I love this graphic from the American Cancer Society. And so just to summarize, many treatments can provide very marginal survival benefits, and oncologists should have honest conversations with patients and care partners about these very, very important non-physical burdens. And I think the field is slowly starting to measure and address all of this, and today's conversation is part of that. So big thanks to my funders and look forward to the conversation. Thank you.
Thank you so much, Dr. Gupta, for that thorough and evidence-based presentation. I mean, it's clear that your work really helps bring visibility to the often invisible toll of survivorship and caregiving. So now we're going to bring Allison back into the conversation for a brief panel discussion. So we're going to explore how both the personal experience that you heard about, Dr. Gupta's clinical and research experience intersect, and where we go from here in supporting caregivers more intentionally. But first, as frequent attendees of the Fireside Chat know, it is not a Fireside Chat discussion without getting our fire started. And this time, since we're in the summer months, we are getting a campfire started. So we're going to dive right in. So Dr. Gupta, I'm going to start with you. What inspired you to focus on caregivers, and why do you think it's important we pay more attention to their needs?
Sure. I'll tell you my personal story. So I grew up in New Delhi, India, and after my grandmom died when I was 11 years old, I actually shared a bedroom with my granddad until I was around 17. And he was my best friend and the greatest person I ever knew. And he was probably my best friend from ages 11 to 17. He was diagnosed with a lymphoma just before I entered medical school. And he actually did quite well in the medical parlance. The cancer was shrinking with chemo, but we used to share a passion for sweets. I still will eat anything sweet at any opportunity. But he would come back from these medical appointments with, the whole family celebrating, and, the cancer shrunk. And all he would come and tell me is, I can't taste gulab jamun. And for those of you who don't know, gulab jamun is an Indian sweet made of everything that's good. There's sugar, milk, dough, and it's deep fried. And all he wanted to do was taste gulab jamun. In fact, the only thing he could taste was ketchup. So he used to put ketchup on gulab jamun and eat that. And I just have that drilled into my memory about how my whole family would be going crazy on how to make grandpa feel okay and feed him, whereas objectively the cancer was shrinking. And those were just early experiences. And then I've chatted with Allison about this. Initially in my clinical practice, I used to focus on caregivers more because I was selfish. If I didn't have a caregiver friend, then I knew that the patient wouldn't be on time for chemo. So I would make it a point to always befriend the caregiver, if you will, and make sure they were doing okay. And over time, I've evolved and become wiser and begun to see their everyday burden and just being more human, I guess.
Thank you, Dr. Gupta, for sharing that. It's really powerful to hear how your own family's experiences shaped your commitment to this work. So Allison, I'm going to actually transition to you. You shared your caregiving journey and how it's been long and complex. So when you hear what Dr. Gupta has shared, what comes to your mind from your own experiences?
Yeah, absolutely. I mean, I think it's also true, right? I mean, my camera was off, but I was nodding so much when he was saying those pieces. And so just thinking about all of the time that we have spent, and that even when you think about the mental piece, like caregivers often say that we are on 24/7. And so someone said to me recently, well, at the end of your shift, and there is no end of shift, like there hasn't been an end of shift for 14 years and counting, right? So I think that I even sort of sleep with one ear open and one eye open. And these last couple of days, we've been waiting for a phone call with test results. And so it just feels like at every moment we're just on. And so I'm just so grateful that he and his team are studying this and are bringing light to this, and that people will sometimes say, oh, you were at the hospital, oh, you were at the clinic, and they can see that part of caregiving. But the fact that his team is shining light on the drive to the clinic, the drive back from the clinic, all of the gymnastics that we have to do to get to the clinic, all that's waiting for us when we get at home, and the paperwork, that all of that adds up as well. And really, it's that unseen part of caregiving that I'm so glad his team is shining light on. I would love, if we can, for Dr. Gupta to just say quick what it is, because this is my favorite part of the other conversation he and I had together. When you have a new patient and caregiver come to your clinic, what is it that you do with each of those caregivers? Because I think we could all learn from that. So would you mind, Dr. Gupta, sharing that?
Of course, thank you. And this is not proprietary. It's something I picked up along the way. But after saying hello and introducing myself, the team, and saying hello to everybody in the room, I think one of the earliest things I've started to do is looking the caregiver in the eye and saying, hi, I see you, and I can't imagine what you've been going through. And what it often leads to is this floodgate opening with tears. And I think they've just kept it bottled inside them for the probably few to several weeks that someone has just been diagnosed and coming to see us. They've probably been doing scans. They haven't met with an oncologist yet. There's so much worry. There's finances, there's bills, and the patient appropriately has taken on the sick role. And it's the caregiver who's handling a lot of it. So I think if there's one piece of advice or actionable takeaway from clinicians, is we don't need to do big magic. I think just acknowledging it and naming it is so incredibly powerful. And I find that visits after that actually go much more beautifully. I think when people once that emotion is out, people actually think more clearly and feel seen and heard and feel more comfortable sharing things that may bother them. For example, if I say that a chemo is done weekly, people feel more comfortable asking, okay, this person cares about me. You know, is it a 1 hour infusion? Is it a 4 hour infusion? Is it only done at this location? Can it be closer to home? So it opens up conversations.
What a beautiful reminder. And also just like you said, I mean, people finally feel seen, and that's kind of why the floodgates have opened, because they've been bottling it up all inside. And so I think that's just a beautiful reminder to any healthcare professionals who's on the call to just take that moment and make the caregiver feel seen throughout this process. And so I am going to now transition a little bit to talk about, we know, and you alluded to this, Allison, that caregiving does not stop when the treatment ends. It does not, the shift never ends. And so, in fact, with survivorship, we know there's a set of new challenges that begin for caregivers. So we'd love to hear from both of you. And Allison, I'll let you start. What does survivorship look like from the caregiver's point of view, and what new challenges does it bring?
Yeah, absolutely. So what I have experienced and also learned from a lot of caregivers is that often it's, you know, when you're in active, the person's in active treatment, you're on and you're going and you're, what's the next thing? And then, you know, you ring the bell and everyone cheers and everyone's excited. And then often that's when the reality hits. That's when the emotions are actually finally able to say, like, what did I just go through? And so I and many others, it's only in that quieter moment when the treatment is over that you actually start to feel all of those feelings, because our bodies are really smart and sort of hold us up as we're going through it. But then when it gets to be a quiet moment, often we collapse. And so that piece happens. Also, at the same time, your community is like, they're great, they're good, they rang the bell, I don't need to bring a casserole anymore, but you're really still going through it, and there's still long-term effects and all of those things. And then there's huge amounts of scanxiety, right? Waiting for, when's the next scan? When's the next scan? Was the alertness doesn't go away. It's still, was that a thing? Was that a symptom? Does that mean it's coming back? And so it's kind of this perfect storm that everybody is celebrating and has left you, but a whole new wave of sort of worries and emotions have come to play.
Dr. Gupta, do you have anything more to add?
I think most things were covered. I'll just add that a caregiver's suffering can unfortunately continue on even after a patient's demise. And some of this is, of course, emotional, but I think it's also financial. And I know there's active legislation in Minnesota about medical debt not being transferred onto patients as caregivers. And I think all of this is so important. You know, medical debt is not like buying a plasma TV. Nobody wants to have medical debt or chose to get all of this. And there's so many of these things that continue on. Yes.
So we're going to just ask one final question before we wrap up this portion of our fireside chat. So you have both talked about really incredible ways that healthcare systems can support caregivers. But if you could change one thing today, what would it be on how healthcare systems can support caregivers today? Allison?
Just one thing. It's hard to pick
To
one.
start.
I think I would wish that healthcare systems could start to see that when there's a patient, there's almost always a second or third or fourth person. and that could be part of the system, and that they could say, okay, you have this diagnosis, and now we have this other person, because they're starting to say that the caregivers are turning into the second patient. But what that means is that we're having these health implications later on. And what I wish is that right from the start, they say, we're going to give you these supports, patient, and you're the caregiver. Great. Here's what we have for you, because you are also part of the story. You are walking alongside them, and we have systems in place to support you all along the way. So that would be my dream.
I love it. Dr. Gupta?
I'll give
One
you
thing.
more. I have a dream, not a dream. I think based on our qualitative work with patients and caregivers, I think the lowest hanging fruit, especially for frequent oncology care, so people getting chemo, people coming in, 6 times a month for this and that, is a dedicated care coordinator and a longitudinal care coordinator who can say, okay, you have labs on Monday and imaging on Tuesday, and can we do them on the same day? And because I have my Pilates class at 3 p.m., can this be right before then? I think we can do so much, but this, I think, is the highest yield, highest bang for the buck, shortest acting thing that we can do.
Well, thank you both so much for the thoughtful and honest conversation on how caregiving exists at the intersection of personal sacrifice, emotional complexity, and system gaps. And so you both just so beautifully highlighted why it's so important that we continue to center caregiver voices as part of the story. You see what I did there, Allison? So now would love to hear from all of you. So we're gonna open the floor up for audience Q&A. So in the remaining time that we have, we're gonna try to get through as many questions as possible. So please, if you haven't already, submit your questions, thoughts, reflections using the Q&A feature. And just a quick reminder, we're not able to address any personal medical questions, but I think we're gonna go ahead and dive in because we've already received some excellent questions so far. Let's take a look here. Oh. Okay, Dr. Gupta, this one is for you. So one person asked, I'm interested in time toxicity and finding the best way to measure and improve it. Can you speak a little bit more about how you're approaching this in your research?
Yep. So the very first measure that we came up with was healthcare contact days, or the days with healthcare contact outside the home. And we've thought about how to modify it for the past couple of years. So it has lots of strengths in the sense that it's very, very intuitive. If I tell someone with this treatment, you'll be coming in 6 times in the next month, and with this treatment, you'll be coming in 3 times in the next month, people immediately get it. And we need that practicality. We need that intuitiveness. The other very good thing about it is that people can apply their own values to it. So someone may live next to the cancer center and actually enjoy coming in and drink the coffee and chat to the nurses and have their social outing. Loneliness is a pandemic as well. Versus someone may live 300 miles away and even one contact day may be too much. So contact days don't make assumptions about patients' experiences and allow people to make sort of their value judgments. So for that reason, contact days is perhaps the best measure that currently exists. We fully acknowledge it's not perfect for a few reasons. So it does not count healthcare within the home. So we automatically say that a home day may be a good day, whereas someone may be very burdened with home-based care. We've had some patients opt to come to the clinic for infusions rather than get home infusions, because in their opinion, at least in the clinic, they always have a quote unquote set time. I'll be there at 9. It may be a little delayed, but I need to show up at 9. Versus at home, what one person described it as was waiting for the Wi-Fi guy. And that means that you don't know if it's 2 p.m. and 4 p.m. And this is nothing against home-based care. I know how hard the home-based healthcare crew work. So so just saying contact days can be burdensome doesn't mean home days are bad. And the last point, which is a negative about contact days, is that many people and populations are vulnerable and face barriers to accessing care. So if you're poor or you're uninsured or you can't get to an appointment, you may have fewer contact days, but that doesn't necessarily mean your care was good. So we need to think about all of this when considering contact days as a measure. In my opinion, I still think it is the best measure we have.
Thank you for that, Dr. Gupta. I know we're kind of quickly approaching the end of our time. So Allison, this question is for you and it speaks to more practical support. Can you share any resources or nonprofits that helped you with medical navigation or even just trusted health information?
At the time, a while ago, there were the American Cancer Society had patient navigators at the clinic. Unfortunately, that's not there at this moment. But that was one person, and really, it was just sort of walking blindly through it. I think that, and part of that is why I ended up starting my own nonprofit. I think that there's a lot of like, here's a flyer for this, and here's a flyer for this, and here's a flyer for this. But if it's not kind of a warm handoff from someone, that can feel really like I don't have the capacity to look at this flyer and comprehend. And so I think that, you know, that's what we're trying to do with the negative space is be that sort of warm presence to support people. Another local Twin Cities organization that I'd love to give a shout out to is Jack's Caregiver Coalition, and they really focus on male caregivers. They do have some things for female caregivers as well. But those, I think that we focus a lot on like on logistical things and resources, but what I tend to find and what I've experienced myself is the emotional support and the being seen and supported and acknowledged is such a huge part of it. And so I think that while it's good to give people flyers for resources that are logistical, I think we also have to support them emotionally, which is what we're hoping to do at the negative space.
And I just want to say, take a moment to say that if you both are seeing what's coming through, a lot of kudos and just appreciation and folks expressing that they did not feel acknowledged. So caregivers were not acknowledged and felt like they were not part of the story. And so just thank you so much for both of you, your time and for the work that you do. And so we are gonna just wrap it up with one more question for both of you before we end things off. But Dr. Gupta and Allison, what is just to wrap it all up and to summarize, what's one thing that you hope folks take away from our conversation today? And Dr. Gupta, I'll let you start.
For patients and caregivers, speak up. The healthcare team wants to help. For the healthcare team, please ask. And we're all in this together.
Bob and Allison?
Yeah, I would say to caregivers, you are part of the story too. This whole thing is impacting you, and it is okay. And for you to say that out loud and to acknowledge that, and that you need and deserve support as well. And to everyone else who is there to support caregivers, to start seeing them and to realize that there are a lot of caregivers in your life, and they need that acknowledgement from you as well. So if you think of all the people in your life right now who are dealing with some sort of injury or illness, think about who's behind the scenes, who's in the negative space, and how can you reach out to them as well.
That is a beautiful way to end off our conversation today. I honestly wish we had more time, and apologies in advance to everyone who submitted questions that we were not able to get to. Thank you again, Dr. Gupta and Allison, for your honesty, your expertise, and your dedication to elevating the caregiver experience. And thank you to everyone who joined us today and for submitting such thoughtful questions. I mean, today's conversation is just a reminder that caregivers are an essential part of the cancer journey and often carry unseen burdens. And so before we close, I just want to make sure that we're leaving everyone with some next steps as well as invitations that I know have been dropped in the chat as well. But for tools and coaching and community that's been designed specifically for caregivers, please check out the Negative Space. You can also explore survivorship resources and upcoming events on the Masonic Cancer Center's survivorship program website. And if you are local to the Twin Cities, as a way to celebrate National Cancer Survivor Month, the Cancer Center is hosting our annual free cancer survivorship picnic. And so it's going to be tomorrow at Roseland Park in Edina from 5 to 8 p.m. It's a relaxed, family-friendly evening to celebrate the Awareness Month with your loved ones. And also there is going to be free food, fun games, and lots of connections. And did I mention again that it is completely free? So we'd love to see a few of you who are local attend. And looking ahead, mark your calendar for our next Fireside Chat on Wednesday, July 16th at 1 p.m. We will be recognizing Bone Cancer Awareness Month. So register today to secure your spot. And before we go, just wanting to make a plug to everyone to complete the brief survey that has been auto-populated once you close the Zoom screen, and also will be sent in the email that's going to go out tomorrow. But your feedback really does help us improve and shape the Fireside Chats to meet your needs. And as a small token of appreciation for your time, you can enter a drawing to win a prize pack filled with goodies from the Masonic Cancer Center after you submit the survey. But thank you again, everyone, for your time today. We hope to see some of you tomorrow at the picnic and also next month for another Fireside Chat conversation. Take care, everyone, and see you all soon.